All right, I think we are just about ready to get started. If that works for you, Dr. Kittleson.
It's great, yes.
Okay, so welcome everyone to another Grand Rounds. Today we are fortunate to be joined by Dr. Michelle Kittleson to talk to us about hot topics in heart transplantation. By way of introduction, Dr. Michelle Kittleson is Professor of Medicine at Cedars-Sinai and Director of Education in Heart Failure and Transplantation at the Smidt Heart Institute. She graduated from Harvard College and received her medical degree from Yale University. She completed residency training at Brigham and Women's Hospital and cardiology fellowship at Johns Hopkins, where she also received a PhD in clinical investigation. Dr. Kittleson is interim editor-in-chief of the Journal of Heart and Lung Transplantation, on writing committees for the ACC AHA Hypertrophic Cardiomyopathy Guidelines and the ACC AHA HFSA Heart Failure Guidelines, co-editor-in-chief for the ACC Heart Failure Self-Assessment Program, and on the board of directors for the Heart Failure Society of America. Her essays and poems have appeared in the New England Journal of Medicine, the Annals of Internal Medicine, and JAMA, and her book, Mastering the Art of Patient Care, is available from Springer Publishing. So with that, I'll let Dr. Kittleson take it away.
Great, thank you so much for the warm welcome. I'm assuming you can hear me okay. I'm so delighted to be here. I'm so sorry I can't be there in person, but as I was saying earlier, my wild animals, also known as my children, do restrict my travel. So thanks so much for having me. Let's dive into hot topics in heart transplantation. I have no disclosures. So the heart transplantation is truly a miracle, isn't it? There are so many pieces that had to work perfectly for it to happen. I just want to tell you a few stories to illustrate the miracle of heart transplantation, where it all began, and what these two pictures have to do with that. So when surgeons were initially thinking about the logistics of heart transplantation, one of the major barriers was the inability to sew delicate blood vessels together. And it was in fact French surgeon Alexis Carrel, inspired by his mother's embroidery circle, who adapted the fine lace needles and silk embroidery thread to pioneer vascular anastomoses, thereby earning him the title Father of the Anastomoses and the Nobel Prize in 1912. So with some of the surgical issues worked out, the next barriers were immunological. And the first heart transplant was performed in Cape Town, South Africa in 1967. But the initial excitement quickly waned because patients didn't do well. And they didn't do well until discovery of this fungus in the 1970s. So back in the olden days, they had a novel form of drug discovery at the pharmaceutical company Sandoz, where employees were encouraged to take plastic bags on holidays with them and collect soil samples. And from one of these, the fungus Talipocladium infladium was isolated in Wisconsin and Norway. They were actually looking for antibiotics. It was a bad antibiotic, but a good immunosuppressant, and cyclosporin was approved by the FDA in 1983. And to get a sense of the impact that cyclosporin had on the world of solid organ transplantation, you only need to look at the volume of heart transplants performed internationally since 1982 and see this dramatic rise in the mid to late 80s, because finally there was immunosuppression that worked. And that's where it all began. And where are we today? So if we look at heart transplant survival in the current era, we see, based on this figure, a lot of important points. Number one, survival has improved in successive eras over the past few decades. Number two, there's a large volume of heart transplants done over the past few decades. We have a lot of experience. And if we look at median survival in the current era, it's about 12 and a half years, which is certainly better than anyone can expect from end-stage heart failure. But it's not just important to live long, it's important to live well. Quality of life matters too. And if you look at data from the International Society of Heart-Lung Transplantation, you can see that the Karnofsky score is a measure of physical functioning. The majority of patients have a score that can be 90% or more, have a good score. In addition, almost half of patients return to full-time employment. And because a picture is worth 1,000 words, I'd like to show you 3 pictures of heart transplant patients living life to the fullest, all shared with approval and permission. So we have one patient climbing the Matterhorn, one of the tallest peaks in the world, another winning the 2017 World Jiu-Jitsu Championship, and another competing in the Kona Ironman triathlon. So what we tell our patients is after transplant, they will not only live longer, but have acceptable, outstanding quality of life. But just because many patients do well does not mean we don't still have challenges and opportunities. So this is a figure from the Scientific Registry of Transplant Recipients database, looking at what happens to patients on the heart transplant waiting list. And you can see that after 3 years, about 2/3 are transplanted, about 10% are still waiting, and 10% have died. And in this gap between those who are successfully transplanted and those who are waiting and don't make it lie many of our challenges and opportunities. And what I want to focus this talk on is a potpourri of some of the advances that are used to solve this problem, used to solve the gap between donors and recipients. And there are essentially 2 general principles that you can use to bridge the gap between donors and recipients. We can salvage more donors, or we can use those donors more wisely. So the hot topics I'm going to talk about are the use of hepatitis C donors, donation after circulatory death, female donors, and antibody sensitization. So let's dive in with Hep C donors. I'm fascinated by the story of hepatitis C organ donation. And it reminds me a little bit of this old meme where, 25 years ago, we'd say, don't get into strangers' cars, don't meet people from the internet. Fast forward a few decades, and we're literally summoning strangers from the internet to get into their cars. And it's that kind of whiplash that I think about when I think about Hep C organ donation. So the story begins back in the 1990s when the thought was we should maximize organ donation with Hep C donors. By 94, most transplant programs were using them. And in fact, a 2001 consensus report from the AHA said Hep C positive donors are appropriate in selected high-risk recipients. And then 2006, when a scientific registry of transplant recipient analysis showed that those recipients of Hep C organ donors had 2-fold increase in mortality, leading to a moratorium on hepatitis C organ donation. And I remember being a medical student in the late 90s and being terrified of being stuck by a needle with someone who had Hep C, even more than HIV. There was a higher transmission rate and no cure until 2014, when the direct-acting antivirals burst onto the scene, now boasting a heretofore unheard of greater than 95% cure rate of Hep C at 12 weeks. The pivotal proof of concept study in the New England Journal in 2017, 10 kidney transplant recipients of Hep C viremic donors cured with normal graft function. So by 2018, we were back to saying, let's maximize organ donation with Hep C donors. And of course, because of the opioid epidemic, there has been a tragic increase in the number of donors with hepatitis C corresponding with the advent of these direct-acting antivirals. And the initial data was really exciting. In the figure here on the left, this looked at the number of heart transplant donors in the United States who were positive for hepatitis C. And you see this dramatic response in the mid-2010s related to the opioid epidemic, but so few actually recovered or used for transplant due to concerns about Hep C organ donation. And if you look at the figure on the right, this is one of the early studies from Vanderbilt on using Hep C organ donors. What I find so striking, each bar was a patient, and the amount of time they waited for transplant in days was red before they consented to a Hep C donor, and blue was after. And you could see not only do we have very high discard rate before direct acting antivirals of Hep C donors, but after consent, a very short time to transplant. So there was initially a lot of excitement that this would be a dramatic way to expand the donor pool. But of course, what you want to know is not just can you transplant them, but how do patients do long term? So for that, we have some UNOS, United Network of Organ Sharing, registry analyses. And if you look from 2015 to 2018, you see an increased utilization of Hep C donors, which is actually makes a lot of sense as programs grow more comfortable with strategies to provide direct acting antivirals to patients. And in a propensity matched analysis with those patients who are nucleic acid test negative, antibody negative, no difference in graft failure 1-year survival. So a lot of support making this our routine standard of care. Of course, the next question becomes, is there a catch? And of course, in medicine, there's almost always a catch. What about this single center study from NYU? It looked at patients who received Hep C positive donors and looked at rejection. What did they find? They found there was more rejection by 180 days, ACR, acute cellular rejection 2R, which is a clinically relevant degree of rejection, 41 versus 18% of patients from Hep C negative donors, and they were more likely to get acute cellular rejection earlier, 26 versus 65 days. So is this applicable? Should we have caution when we use Hep C positive, nucleic acid test positive donors for our heart transplant recipients? Maybe not. Let's look at the fine print of the study. This single center had a very unique protocol for managing immunosuppression. Prednisone was weaned off at 3 months, where typically centers might not wean prednisone until between 6 and 12 months, and for some patients continue it indefinitely. Second, the goal tacrolimus level was 8, which might be a little low early after transplant. And speaking to the lack of potential widespread applicability of this study, if you look at the ISHLT registry, they say about 12.5 patients have rejection by 1 year, yet in this study there was 18% at 6 months. So for our purposes, Hep C organ donation has become the standard of care with comparable survival and no concern for increased rejection depending on the immunosuppression protocol used. Our protocol is to exclude patients who have fibrosis on liver biopsy, if we're concerned at all about their liver function, and then they will be tested with a Hep C PCR on post-op day 1 and weekly until they turn positive. Notice I didn't say unless or if they turn positive, it's more of a when. They will become viremic from receipt of a donor from a Hep C nucleic acid test positive viremic donor. And then they'll start therapy. And we'll use one of 2 regimens, the most important caveat being, has the transplant recipient received amiodarone? Because there's a black box warning for the use of sofosbuvir with patients who've received amiodarone, as it can lead to potential significant bradycardia. And in our experience, I'm sure is similar to that at UCSF, we have documented sustained virological response by 12 weeks in all these patients. So over the past 5 years, a really huge advance for our patients. So let's talk about other ways to salvage more donors. Let's talk about donation after circulatory death. And I really love this quote by Edgar Allan Poe. Heart transplant didn't exist in 1844, but he kind of had a sense of what the ethical quandaries we would be dealing with when he said, "The boundaries which divide life from death are at best shadowy and vague. Who shall say where one life ends and where the other begins?" I think that's really quite prescient. And in fact, donation after circulatory death was the practice of that very first heart transplant done in Cape Town, South Africa in December 1967. And in fact, as soon as the donor had been certified dead, when the electrocardiogram had shown no activity for 5 minutes and there was absence of any respiratory movements and reflexes, the donor's chest was opened, bypass and cooling commenced, heart excised, and transferred to the adjacent theater or operating room. So that was the initial experience. However, there was in 1968 a special committee convened at the Harvard Medical School to examine the definition of brain death. Why? What was the impetus for this? Well, the purpose was to decrease the burden on family and society that continued medical therapy could create, and to update obsolete criteria for death that led to controversy in obtaining organs for transplantation. And based on this special communication, it was noted that brain death could exist without cessation of cardiopulmonary function. This was the foundation of the Uniform Brain Death Act of 1978, the Uniform Determination of Death Act of 1980, which led to the standard of care for donation after brain death, or DBD. But while it's the standard for organ donation, and there are a lot of advantages to this, because your organ is being perfused during retrieval, because there is no cessation of cardiopulmonary function, there's the ability to assess organ function pre-transplant. The one concern is there are so many strict criteria to donation of brain death, whereas there can be a potential recipient who checks off not all the criteria, but has had a catastrophic brain event from which there is no meaningful recovery and could not be considered under donation by brain death alone, which has led to this other concept of donation after circulatory death, or DCD. And this is a nice schematic that highlights the differences in the process. So let's go through that. First, the clinicians who provide end-of-life care, who identify a catastrophic injury for which there is no meaningful recovery, are distinct from those who participate in transplant. The second important thing to note is when the decision is then made that the organ donor is an acceptable candidate with the appropriate consents and medical assessment, there has to be a standoff period to ensure mechanical asystole for 5 minutes, because studies show there's minimal risk of auto resuscitation after that period of time. And the transplant team is not present until death has been declared. But it's tricky, because instead of having a period of continuous cardiopulmonary function up to the point of organ recovery, you have in controlled donation after circulatory death a body that is dwindling, a systolic blood pressure that is falling, which leads to this period of warm ischemic time, which has to be limited in order to preserve the function of the organ. And so there's very distinct features to donation after circulatory death. So let's talk about what happens to the heart, because we said in donation after brain death, you can assess the organ function, it's being constantly perfused, you take it out and you go. In this situation, you have to reperfuse the heart at some point after death has been declared, circulatory death has been declared. And that reperfusion of the heart, that reanimation, has to either happen at procurement in situ in the donor or during transport ex situ. So let's talk about the different options for procurement and transport. You can have direct procurement and perfusion, that is just take out the heart just like you would in a donation after brain death, or you can reperfuse, reanimate the heart in the donor using thoracoabdominal normothermic regional perfusion, essentially putting the recipient on cardiopulmonary bypass to wake up the heart again, clipping the carotid vessel so the brain does not get reperfused, and that's why it's called thoracoabdominal normothermic regional perfusion. Now, the advantages to DPP, direct procurement, is you can explant the heart as quickly as possible, the caveat being no in situ perfusion. The advantages to TA-NRP is that you have mechanical perfusion of the heart in situ using cardiopulmonary bypass or ECMO, ligate those vessels. And then you have two options for transport. You can have static cold storage or normothermic machine perfusion. So static cold storage is the old school Coleman cooler. It could either happen with co-located or relatively close recipients, but there's no ex situ perfusion in this option. With normothermic machine perfusion, there are these perfusion platforms like the organ care system. So if you're thinking about one from column A, one from column B, what can I do? You basically could never do direct procurement and perfusion with static cold storage because you have not reperfused, reanimated the heart at any point in the process. But otherwise, any of the other options are possible. And we'll talk about the relative benefits, disadvantages, advantages of these various approaches. To show it again, the traditional pathway is just take out the heart, put it in the recipient. The new and I should say, if there's any cardiothoracic surgeons listening to my talk, I apologize in advance. You guys are superheroes. I would faint dead away in the OR if I had to cut anyone open. So forgive the simplicity with which I'm describing the very delicate technical mastery that you do. And then if it's donation after circulatory death, you got to perfuse at some point, either in the donor or during transport. So our choices are direct procurement with normothermic machine perfusion, take it out, perfuse during transport, normothermic regional perfusion with machine perfusion, reperfuse both in the donor and during transport, or reperfuse in the donor and then put it in the cooler for transport. So those are the three options. All of them have pre-implant viability assessment, which is absolutely critical. Distant procurement is concerning when you use static cold storage. How long is that ischemic time good for? The one problem with normothermic regional perfusion, that is reperfusing, reanimating the heart in the donor, is that it does require some ante-mortem intervention, and that can be ethically problematic. But the problem with reperfusion during transport, these ex situ perfusion platforms like the organ care system, is that they institute a lot of expense. So you can see there's pluses and minuses. So those are your options. Let's talk about how patients do. Let's talk about the learning curve. So some of the first reports came out of Australia using direct procurement, that is just take the heart out like you normally would, normothermic machine perfusion, use an ex situ perfusion platform during transport. 1 year survival, 95, 98%, but a lot of primary graft dysfunction, but a third of patients needed ECMO post-transplant as a bridge to recovery of primary graft dysfunction. Then there's a study a little bit larger from the UK, and they use a lot of various methods, but a lot of normothermic regional perfusion, perfusing the heart in the donor before transport. Still good survival, no increase in post-transplant mechanical circulatory support for primary graft dysfunction. So I think the learning curve tells us that the TANRP, that is perfusing the donor before procurement, can minimize the ischemic time, allows this early functional assessment of the heart. Perhaps the other part of this learning curve, which improved outcomes, was better donor selection, avoiding those donors with prolonged ischemic times, waiting for withdrawal of life support. So, and let's turn now from these early experiences to what we know moving forward. So this is a really nice paper that came out a few years ago, an early US experience from Vanderbilt, where they used the normothermic regional perfusion, perfuse the heart in the donor, and then put it in a cooler to bring it to the recipient. They had great early survival, no severe primary graft dysfunction, PGD requiring ECMO, and they went to ischemic times up to 225 minutes. So a really nice proof of concept for the use of static cold storage to bring down the cost of this technique. But of course, the big study we all talk about, super exciting, came out last year in the New England Journal, was the DCD heart trial. 180 patients at 13 centers, randomized to direct procurement, take it out like you normally would, avoiding any ethical issues of normothermic regional perfusion, putting it on one of those ex situ perfusion platforms, or donation after brain death. What do we need to know about the study? One, the DCD utilization rate was really high. If you can think about it, you get a call, here's a donor, you have to predict the future. Will withdrawal of life support be short enough so that the warm ischemic time isn't so long that the heart starts to deteriorate before procurement? They did a good job in this study, 89% utilization rate. Also, the other part, though, is even though 6 months survival was quite good, it met the non-inferiority margin, the risk of moderate to severe PGD, while higher, was still likely acceptable. The one difference is sicker patients were less likely to get a heart from donation after circulatory death. So even though it was randomized, of course, the clinician has to ultimately decide, am I going to accept this heart for this patient? And there's got to be some human nature involved that I'm a little concerned about our comfort with DCD, and I don't really want to use it for this higher risk patient. That may have played a role. Clinicians seem to use the DCD hearts for less sick recipients. That being said, a huge advance in the field to show that this is feasible with good outcomes. And let me give a shout out to two of your surgeons who were authors on this really important trial, Dr. Smidt and Dr. Fiedler. So that's the DCD heart trial. Let's talk about the implications. What could this mean for our patients? So some of the early projections out of the United Kingdom were that they could have a 50% increase in donors if they could accept donors after circulatory death, a much wider umbrella than the strict legal criteria of brain death. And if we look even in the United States, there was a 68% increase in DCD hearts in 2022. It's really incredible. Over 4,000 heart transplants performed in the US in 2022. I mean, it used to be about 2,500 a year. It's astonishing. I never thought we'd ever get to this many. And the greatest increase was in the use of donation after circulatory death, a huge benefit to our patients. That being said, there are potential barriers to implementation. We have these, articles in the lay press about mistrust of the organ donation community, taking hearts from patients who are not brain dead. In fact, the American College of Physicians put forth this statement against the use of normothermic regional perfusion. So there's a lot to still uncover and solve, but there's no question this offers hope to so many patients on the waiting list. So that takes us through 2 ways to salvage more donors. Now, let's talk about recent advances over the past 5 years and how we can use our donors more wisely. Let's talk about female donors. Let's talk about donor call, which most commonly happens at 2 in the morning, and you're woken up out of a deep sleep to review this donor, female 20, 5'10", 141 pounds. Recipient is male 60, 5'1", 176 pounds. And you remember, even though you're sleep deprived fog, that any young donor is perfect until proven otherwise. However, you have pause when you think about putting a female donor into a male recipient. Why? Because of these likely outdated guidelines from 2010 that tell us that use of a female donor whose weight is more than 20% lower than that of a male recipient should be viewed with caution. Now, these candidate guidelines are in fact being revised and should come out shortly, but this was the classic teaching for many years, and it was based on multiple registry analyses that showed that male recipients fare worse with female donors and female recipients fare the same with female versus male donors. So if you put a female donor into a male recipient, about a 30% increased mortality. So the question is why? What is it about this toxic combination of a female donor into a male recipient? Is it biology? Is it immunology? Is it hormonal? Is it revenge? Well, probably not revenge. Really, what it likely boils down to is size. So it's a really fascinating analysis that took donor recipient sex categories in UNOS and then spread them based on what was the difference in body weight. And if you look just at body weight, those are the histograms in the left panel, you see that donor-recipient weight distribution is actually uniform among sex categories, so there's no signal there. But if you look at a different size metric, you see, in fact, that female donor into the male recipient is undersized. So there's a signal here that size matters, and it's not body weight, but predicted heart mass, or PHM. Because if you think about it, when we look at the height of a recipient donor, the weight of the recipient and the donor, what we're really trying to get at is what's the size of the heart. And weight is a unidimensional construct, height is a unidimensional construct, but there's so many parts that go into that. And predicted heart mass is based on MRI studies and takes into account a constant that's different for men and women, height raised to a power, weight raised to a power. So it's a much more useful multidimensional construct. And one of my colleagues, Evan Kransdorf, did this really lovely analysis of the UNOS registry a few years ago, dividing patients into categories, oversized, undersized, for various size metrics. And what he found was that only one size metric predicted outcomes. And in fact, undersizing by predicted heart mass was associated with a 34% increase in one-year mortality, quite similar to those prior analyses showing a 30% increase in mortality when you put a female recipient into a male donor. The magic number was 0.86, which we had supposed was perhaps the minimum myocardial mass needed for adequate circulatory support. So this is a really big game changer. And if you think about the implications of this, if you spent your life on donor call avoiding female donors for male recipients, were patients missing out on good hearts? So this analysis of the donor pool showed that the answer is yes. So the histograms at the top were offers turned down for size, because every time you turn down a donor to UNOS, you have to give a reason why. It's recorded in the database. And you can see here, these are histograms for male donors to male recipients, male to female recipients, all the sex categories. The red line being acceptable predicted heart mass. And you can see that 32% offers turned down for size had an acceptable predicted heart mass ratio and could have resulted in acceptable outcomes. So think of all those missed opportunities to potentially transplant the patient. And if you look at offers accepted and look at that female donor to male recipient, about half actually had an inadequate predicted heart mass with predicted increased mortality. So having predicted heart mass as a tool instead of just sex matching has allowed us to use donors more wisely. So if you are on donor call at 2 in the morning and you're sleep fog and you heard all this stuff and you say to yourself, oh my gosh, I need to figure out the predicted heart mass, but I can't do exponents in my head, don't worry, your coordinator will have access to the UNOS predicted heart mass calculator and show you that the predicted heart mass is likely acceptable, and all other things being equal, it's okay to proceed. So that takes us through one of the two ways we can use donors more wisely. Let's end our potpourri of advances by talking about antibody sensitization. So what is antibody sensitization? So when you have a donor heart going into a recipient, the immune system has a heightened awareness to this scary new foreign object, and the targets of the antibody response are the human leukocyte antigens, or HLA, present on the surface of all nucleated cells. Risk factors for sensitization include exposure to foreign HLA, which can happen with blood transfusions because some nucleated cells sneak in, pregnancy, previous transplant, and mechanical circulatory support devices. A bit mysterious. It's not just related to blood transfusion, so that's a big part of it. So the goal is you want to identify those sensitized patients before they undergo transplant to figure out how to handle the sensitization in the transplant candidate. Now, these are called HLA antibodies. The old school name is panel reactive antibodies, or PRA. That name comes from the fact that in the olden days, immunology labs would take a panel of blood from various volunteers, mix patient samples with them, and see what agglutinated or lit up or clumped together to figure out what anti-HLA antibodies were present. So that's why it's called panel reactive antibodies, synonymous with anti-HLA. So here's the protocol we used for our sensitized patients. Any heart transplant candidate is going to have assessment of anti-HLA antibodies. We want to know three things. Are they there, and which ones are there? That's the identity. How strong are they, based on the median fluorescent intensity or dilution? And what about the function? Do they fix complement? That would be a C1q assay. There will be center-specific thresholds for concern. We use an MFI above 5,000, present after dilution, complement binding, and if present, we have to figure out what to do with our transplant candidate. And I'm going to focus here on what do you do with this candidate when an offer is available. And for that, we have to use the cross-match. So let's talk about how the cross-match works. We have a highly sensitized patient. That offer has become available. It's the right size. It's the right blood type. They're the next on the list for urgency. They've got all these antibodies. So we're doing a cross-match. What do we do next? So there's two ways to do the cross-match. A cross-match is basically your way of predicting the future. If I put this heart into this recipient, will it die right away due to hyperacute rejection immune response? But you'd like to figure that out in a test tube before you figure it out in the patient. So that's the purpose of the cross-match. You take the recipient's sera containing their anti-HLA antibodies, you mix it with donor lymphocytes, and then you can do one of two things. You can add complement to see if the cells die. That's a CDC, or complement-dependent cytotoxicity cross-match. That will tell you if antibodies are present and they can kill. The second type of information you can get is mixing the sera with the donor lymphocytes, then add fluorescent conjugated anti-human globulin, pass it through a flow cytometer, and that'll tell you that antibodies are present, but you don't really know the killing potential. So I like to say that a CDC cross-match is hyperacute rejection in a test tube. No one's going to do the same thing twice and accept a different result, because that would be insane. But what about a flow cross-match? Is that really bad? Well, if you look at the study on the left from over 2 decades ago, yes, a positive flow cross-match leads to decreased survival. But a decade later, through use of things like IVIG or rituximab, a positive flow cross-match was not associated with an increased risk of death, but increased rejection. So what do you do when you have a patient who's highly sensitized? How do you interpret your cross-match? Well, if it's negative flow and negative CDC, you crack open a bottle of champagne to enjoy after the transplant's done. If the CDC is positive, we remember that we don't want to repeat the same experiment twice. This one in the patient, you turn down the heart. But what if you have a positive flow cross-match and a negative complement-dependent cytotoxicity? Some centers would use ATG, plasmapheresis, IVIG, rituximab. At our program, we have gone to eculizumab as our go-to for these highly sensitized patients with donor-specific antibodies identified on the flow cross-match. So eculizumab is this humanized monoclonal antibody that binds to and prevents activation of complement component C5. It's FDA approved for treatment of PNH. It's a complement-mediated condition. So if you think about it, antigen-antibody complexes bind, but they're not necessarily deadly until they bind C1 and the complement cascade begins. Flashbacks to medical school here, and it culminates in the formation of the membrane attack complex and cell death. Eculizumab, in inhibiting C5, cuts off the complement cascade at its knees so the membrane attack complex can't form. So it's like you've got the gun and you've got the bullets, but you're preventing them from going together to actually be deadly. So that's the proof, that's the theory. The practical proof of principle came through the DUET cardiac study that we performed a few years ago. It was our single center study of 20 highly sensitized patients who had to have a positive flow cross-match and at least one donor-specific antibody. They underwent transplant and received eculizumab at release of aortic cross-clamp and then weekly for the next 7 weeks. We found that their survival was 90%. They all had donor-specific antibodies, no cellular rejection, very low risk of antibody-mediated rejection, no graft dysfunction, and some treated infections. We were very excited about these results because the international standards for 1-year survival after transplant are about 90%. So to achieve that in this highly sensitized group of patients who had no other hope of ever getting a heart was a huge deal. But I know what you're asking yourself. You're saying, maybe they would have done that well without the eculizumab. Where's your control group? So we went back through our files trying to look for patients with a positive flow cross-match who we transplanted before we had eculizumab in our armamentarium, and we could find none because we were too chicken to transplant against a positive flow cross-match before eculizumab. But fortunately, our friends in France were more courageous and let us take their data. And what we found was, compared to their patients who just received plasmapheresis and IVIG, we had less rejection, episodes over time, fewer number, fewer and longer onset. So truly, eculizumab has become our hope for these highly sensitized patients to use our donors more widely. So we've covered ways to bridge the gap between donors and recipients, salvaging more donors with Hep C organ donation, donation after circulatory death, using our donors more wisely with female donors, and approach to antibody sensitization. We've started out with some long-held truths in transplantation. Don't accept a donor with Hep C. Donation after circulatory death isn't medically or ethically feasible. Don't put a female heart into a male recipient. Don't transplant against a positive flow cross-match. And I hope I've convinced you in the past 40 minutes or so that these are in fact myths. And the truths are that Hep C donors allowed us to trade a fatal disease, advanced heart failure, for a curable one, that donation after circulatory death should become the standard in transplantation, that we don't match sex, we match predicted heart mass, and that a positive flow cross-match is surmountable with eculizumab. Well, I'd like to thank you so much for your attention. And while self-promotion makes me a little nervous, my editor made me promise that if I ever give a talk, I have to include this as the last slide. So please tell your trainees about this book, available on Springer, likely free through UCSF's institutional subscription. It's filled with everything I've learned from my mistakes and the wisdom of my mentors, and I hope it's helpful. Thanks so much for your attention.
Thank you, Dr. Kittleson, for the truly tour de force presentation. I'll add to the promotion of your X / formerly known as Twitter account, which I've been following since residency. I know includes many of the pearls that may be featured in that book. I'll note that many members of our transplant and advanced heart failure team are in attendance, so including Dr. Smith, and thank you for that shout out for their paper. I'll note that Dr. Fiedler will be joining us in April for Grand Rounds, but I'll open up the floor for questions and comments from the audience.
I had one question, Dr. Kittleson. When you're, is there any type of patient population that you get nervous about using eculizumab in, or any certain toxicities that we should really be watching out for?
Yeah, so of course it'll increase your risk of infection, particularly with encapsulated organisms. So a meningitis vaccine is recommended as far prior to transplant as you can do it. And if you can't give the meningitis vaccine, meningococcal vaccine, because you know status 1, 2, and there's no time to it, you get prophylaxis for usually 9 weeks or so. Transplant 2 weeks after the last dose. That's the first thing. And of course, they will have an increased risk of infection because they've received it. Typically, if they have an infection bad enough to contraindicate eculizumab, they have an infection bad enough that they're not going to be actively listed for transplant. transplant. So short of accepting the risk of waiting forever in a highly sensitized patient and all the risks of borrowed time on the wait list, with the post-transplant risk of infection, it generally tends to, we err on the side of get them transplanted and give the eculizumab.
Thank you.
Dr. Kittleson, thank you for that wonderful tour through the last decade of heart transplantation. I had a quick question. We are trying to catch up with some of the cutting edge programs who have been engaged in the HALT-D or heart after liver with domino transplants for this very issue of the highly sensitized patient and trying to avoid some, severe immunologic modulation and the risk of infection. And was wondering if you all have ventured down that road or if you've had conversations with folks in that space and where to draw the line for antibodies that you're willing to cross in a heart after liver scenario.
Great question. We talk a lot about heart after liver transplant. We have never done one, and I'll tell you our concerns. Number one is logistics. I mean, a liver has an ischemic time of 24 hours, a heart maybe has an ischemic time of 4 hours. Just wrapping our head around how we're going to get it done in a timely fashion has really befuddled our multidisciplinary teams, number one. Number two, in the paper, the landmark paper we talk about from the Mayo Clinic of their case series of highly sensitized patients who were successfully transplanted, a proportion of those also received eculizumab. So it's hard for me to tease out how much was the liver and how much was the eculizumab. And third, there is a bit, I think we have some ethical equipoise and uncertainty about giving someone 2 organs for that indication when their liver is otherwise fine. Yeah, you could domino into someone else, but just the act of doing this ginormous surgery of a heart-liver transplant. So for the issues that are ethical and logistic and questionably medically, we've erred on the side of eculizumab as getting our patients through. So typically for us, if you're highly sensitized, say your CPRA, you're broadly sensitized, your CPRA is measured at 50 to 70% for any MFI above 10,000, and or you have strong antibodies on 1 to 8 dilution and complement fixation, you're in that bucket, you've pretty much bought yourself a prospective cross-match. We don't feel a virtual cross-match is acceptable when you've got that broad degree of sensitization. If you only have 1 or 2 strong ones, it's easy. If you have more, it's hard to predict the future. And then if the CDC is positive, sorry, but no, maybe someday when we have IDIS, the IgG degrading enzyme, strep pyogenes, but we don't have that yet. So for now, if you have positive CDC, no, positive flow, back off eculizumab.
Any other questions from the audience? If not, we can adjourn the meeting slightly early.
Sure.
Thank you again, Dr. Kittleson. I think perhaps we don't have questions because it was so comprehensive. And thanks again for joining us. Another plug to everyone that we will have a little bit more on the surgical perspective in April. So thanks again for joining, everyone.
Great. Thank you so much for the invitation. Have a good day.
Thank you.